For any of you that I haven't met before, I'm Lisa Galligan-Dawson. I'm the Director of Performance for Greater Manchester Cancer Alliance. This is my bread and butter to talk about performance and rules of engagement. And what I want to try to do is to give you the information in a way that you can understand it, but I'll start off by telling you about the changes, so the factual parts and what's changed, and then I'll go on to how that will impact patients. And I would ask you to make a note of questions as you go along. I may get to them as part of the presentation. So to start off with, I want to talk to you about the main changes from a cancer waiting times perspective. So most of you will be familiar with the original standards, and just looking at the screen, they're the ones on the left hand side. So there has been 9 constitutional standards and 1 additional standard that's been monitored but doesn't form part of the Constitution. That's the one that relates to consultant upgrades. And NHS England have been working on a revised set of rules and measures for quite some time now, and that's been through all of the appropriate sign-off processes in government, and those new measures were announced in September to commence in October of this year. So those 9 formal measures and the 1 informal have been replaced by 3 standards. So the first of those standards monitors the point from referral or clock start through to the point in which a patient is told that they do or they don't have cancer, and that's the faster diagnosis standard. And that measure is part of the existing standards and remains unchanged, but it becomes more prominent as the first of those 3 metrics. The second standard combines the 31-day measures that we had in place. So we had a 31-day decision to treat standard for patients that had a new cancer, and we also had a 31-day standard for subsequent treatment. So somebody that's perhaps had chemotherapy as their first treatment but then goes on to surgery, or somebody that's had surgery followed by radiotherapy, and those metrics have been combined into one. So the new standard for all 31-day decision to treatment standards have been combined, and there's a new operational standard of 96%. And then perhaps the most significant of the metrics, in my view anyway, is the 62-day metric. Now, we've always known that the 62-day metric is important, but we've always monitored the screening, the breast symptomatic, and then consultant upgrades separately. So for the first time, they become an amalgamated standard. So the 62-day standard is now a combination of those patients that start a cancer pathway because they've been to see a GP, those patients that are part of a consultant upgrade, so patients who have attended an appointment routinely but been cancer and upgraded onto a 62-day pathway, those breast patients that the GP perhaps doesn't think to start off with that their symptoms are suggestive of cancer, but they turn out to be cancer, and patients that enter a cancer pathway because of a screening programme are all treated the same now under one standard, and that's 85% of patients should start their first definitive treatment within 62 days. One of the other major changes is the one that's perhaps caused most anxiety in our patient groups, and that is the removal of the original 14-day standard. So it was known as our 2-week wait standard. So patients referred in used to be required to be seen within 14 days. And that standard's been withdrawn from the 1st of October. Now, there is a really sound rationale behind that, and that is that 2 weeks is too long. And many of you that are on the call will have sat in pathway boards and in workshops where we've talked about the importance of seeing patients early in the pathway to allow us enough time to diagnose and treat within 62 days. And talked about the importance of seeing patients quickly to reduce the stress and the anxiety of waiting to find out if there's something wrong. And much of the work that's been generated and is our sort of bread and butter now is the work on delivering the best practice time pathways. And really, waiting 2 weeks from the first appointment doesn't align with any of those documents and those best practice standards. So the rationale for removing it is because the focus needs to be on delivering the best practice time pathway milestones, and with the focus on faster diagnosis. That's kind of where the changes come from. But I think it's still a really important metric for us to understand and to make sure that we don't see any detrimental impact on that. So we will still collect all of that waiting time, attendance information. We will still report that. Certainly we'll use that for operational use to monitor how quickly people are seen and what that offer is. And I guess that's another important element. You know, we want that appointment or that first attendance to be of high quality. We want it to not just be okay, you've been referred in and we need to send you for some diagnostics. We want to try and either do that on the same day or have the diagnostics before the appointment. So much of it is around how we've been redesigning our pathway. But one of the things that you will notice is a change in the terminology that we use. Now, we've probably all been here long enough to know that we always use the acronyms to 2 week wait to describe patients referred in on a cancer pathway from a GP. But that terminology is changing to being a suspected cancer referral. So a GP suspected cancer referral with the acronym SCR. And unfortunately for many, it's the same acronym that we use to describe the Somerset Cancer System. But nevertheless, that's the language that we're navigating to, because 2 weeks isn't the standard anymore. And we know that we have got some operational challenges, and it's better to be using the new language than to be creating false sense of securities or telling people it'd be 2 weeks when it might be 3 days. So it just helps us to frame that new term. So I just wanted to talk a little bit and to provide some reassurance to you about how we view and monitor some of these changes. So we talked about the 31-day pathway and the importance of that from a treatment perspective. But when you amalgamate it all together, they become very high numbers, and a percentage can take away from the detail underneath. So I guess that we wanted to provide some assurance around that. So we will still report all of those metrics individually from an operational and a pathway management perspective. And that's so that we can really understand if there's a change, where that change has come from, because a pathway for surgery versus chemotherapy versus radiotherapy are all very, very different in terms of how they are delivered. And actually a percentage change overall might not reflect a problem everywhere. It might just reflect one particular modality, for example. So we'll still be monitoring that individually, and we'll report that by tumour site as well, so that we don't get lost in a big number. Overall, we can really see the detail underneath. And from an improvement perspective, they're the things that you'll need to know that we're monitoring and working towards. There are a couple of changes within some of the recording elements. So there's a couple of things that have been excluded just to try and not skew the figures. But there's nothing in there that's particularly different other than the amalgamation of the standards. The 62-day, as we just mentioned, though, is really different. And I think that this is much better for patients. For me, this brings parity between those different referral sources, and it's really important to have that same visibility over screening and consultant upgrades, in my opinion. Again, though, from an assurance perspective, we will still report all of those metrics individually from a pathway management perspective, and we'll report them almost in a disaggregated way. So we'll be able to report the pathways that end in surgery compared to the pathways that end in chemotherapy, to really understand the differences and the makeup of our performance. And there's one other thing in relation to the 62-day change that I think is a really important aspect for you to be aware of, and that's almost a backstop that's been put in to ensure that there's parity on when consultant upgrades take place. And the rules have not changed on that. It should be the point in which cancer is first suspected. But there is a backstop now to say that when a patient attends an MDT to be discussed because there is suspicion of cancer, that's the latest point that they can be upgraded. And that's designed to manage and make sure that people are upgraded correctly. Now, we don't have a problem with this in Greater Manchester. We've got very good processes for patients being upgraded, but nevertheless, it does provide us with a backstop and a safety net. And we talked about the faster diagnosis standard being the other one of those three standards. And I guess that this is unchanged in terms of how it's calculated and what it means. But I think there are a couple of important points just for us to. So just for clarity, the faster diagnosis clock stops at the point that the patient is informed that cancer is either confirmed or excluded. It's not when a CT is reported, it's not when the histology is reported, it's when the patient's informed. The other thing is that the faster diagnosis standard is not intended to result in any patient waiting longer for a first appointment. But I know that if you've got specialties like breast and skin, they have kind of a results on the day kind of service. That's their pathway. So breast has a triple assessment, so you would know the output on the day. So the intention is that you don't wait till day 27 to first see somebody and then do everything on the day. The intention is that acts as a safety mechanism to make sure that people do know the outcome by day 28, and those that have that on a one stop, that should still be early in the pathway. The other things that we do know is that there is potentially going to be some pathway level targets for faster diagnosis, so in particular for skin and breast, and that comes back to making sure that people don't just wait longer for that first kind of on the day results appointment. So there's an expectation that rather than being at 75%, that those two areas would be at 90%. And we know that there is a likely move from the overall standard of 75% to 80%. That's not going to come in for another 18 months. That's our understanding. Things might change when the targets for next year come out in the planning guidance, but that's what we understand at this stage. And then I guess, what does all of this mean in reality for patients? And I guess this is the bit that I wanted to frame in. That's the factual things. They are the things that have changed, but what does it mean to individuals? So I don't think we are expecting there to be any change to the way that we see patients when they are referred into a hospital for care. There is no intention that those changes mean that we no longer see people in the early part of the pathway. On the contrary, I think that the refocus on 62 days means that there will be more of a focus of that front end, but we will monitor that. We'll keep monitoring it and make sure there's no unintended consequence. I don't think that we're expecting any negative impact either in the combined 62 and 31 day standards. My view is that will increase the focus on 62 days, including patients on a consultant upgrade and screening pathway. And I think that's a good thing for patients. There will be more scrutiny on the deliverables, and I think that's helpful. Very much the last couple of years have focused on patients waiting over 62 days on a PTL. That's still really, really important, but getting back to the 62-day standard, I think, is pivotal and will be helpful in terms of making sure that we keep cancer at the top of the agenda. The one thing that we do think, though, that will be different for patients is that GPs will give slightly different information when referring a patient. So the standard response, I think, in most areas has been, oh, and you should be seen in 2 weeks, and if you've not, come back to us. And actually, that's a different messaging these days. So we're just working through what that might be. I think in general, the information that's being given at the moment is, if you've not heard anything from the hospital in 10 days, call us back, from a safety netting perspective. But we are looking to see how we can make that more efficient and effective for patients. But in essence, I think my summary is that the changes are good in terms of the focus on 62 days and 31 days. I think and understandably, I think for people, the removal of the 2-week wait standard, the 14-day standard, does cause some angst. I think the sentiment is the right thing to do, to really focus on those milestone weights and the best practice time pathway, but we will have to monitor that really carefully moving forward. So that's the information on the changes to the guidance. and hopefully provide some reassurance of what that means in terms of day-to-day operational work and how those pathways are managed, and that if anything this is seen as a good thing for patients. But very, very happy to open for discussion and conversation, either on any questions in relation to the factual stuff, what's changing, or in terms of what that means in reality for patients.